And my hope today is that seeing your experiences reflected in these numbers feels validating. So here's a quick look at what I'll cover today. I'll start with some background on SCAD and why this research was needed, then walk through who was part of the survey, and many of you may even be among them, and how we approached the analysis. And from there, I'll share what SCAD patients told us in their own words, followed by the numbers behind those experiences, and end with what it all means going forward. So, what is SCAD? Most of you know this firsthand, but I want to ground us in a few facts for the research context. SCAD is a non-atherosclerotic cause of heart attack, meaning it is not the plaque buildup most people picture with a typical heart attack. Instead, it's a spontaneous tear or disruption in the coronary artery wall that reduces blood flow to the heart. What makes SCAD so important to study is that it most commonly affects women under the age of 50 and may account for up to about a third of heart attacks in that group. And unlike traditional cardiovascular disease, it often shows up in people without the classic risk factors, so no high blood pressure and no high cholesterol. It's frequently linked to fibromuscular dysplasia or FMD, a condition affecting the artery walls themselves. And even though awareness has grown, SCAD is still underdiagnosed and understudied. And beyond the physical event itself, it carries a real psychological burden. And that's really what the heart of this research is about. So research on SCAD has grown a lot in recent years, which is encouraging, but most of it still looks pretty similar. A lot of it comes from single clinics with fairly small number of patients, which makes it hard to know how well the findings apply broadly. There's been some research on mental health after SCAD regarding anxiety, depression, emotional distress, but it's still fairly limited. In particular, we don't know enough about what patients actually experience day to day. What was missing was research with larger, more diverse groups of participants and space for people to describe their experiences in their own words and not just check boxes on a survey. And that's what motivated this study. So this study was designed with a few of those gaps in mind. First, we used a mixed methods approach, which combines the numeric survey data, things like checkboxes and rating scales, along with your own written responses to open-ended questions. Numbers alone can show us patterns, but they can't fully capture what it actually feels like to go through this, and so we wanted to look at both. Second, we had over 1,200 participants take part, which is a much bigger group than most SCAD studies have had. A lot of prior research came out of a single hospital system, like just one institution's patient population, rather than SCAD patients from all over. And this survey reached people from multiple countries, not just one clinic or one region. So, bringing in your words and experiences, especially around mental health, let us capture things that don't fully show up when a study only looks at medical records. And although this design let us look at mental health after SCAD more fully and start closing some of those gaps. So looking at participant characteristics, this slide gives you a sense of who was part of this study. In total, 1,217 people responded to the survey, which is a much larger group than most SCAD's research has looked at before. The sample was predominantly female, which lines up with what we know about who SCAD tends to affect, and it spanned a wide age range, so we're capturing people at very different points in their recovery. And you can also see how global this response was. 22 countries across 5 continents. So wherever you're joining from today, there's a good chance someone from a similar part of the world took part too. So because we ran 2 different types of analysis, we worked with 2 slightly different groups within that larger sample of the over 1,200, sorry. The qualitative side, where we looked at participants' written answers, included 712 respondents. And the quantitative side, where we ran the statistical analysis, was limited to 895 female respondents, since few men responded that we couldn't draw reliable comparisons from that group. Both groups looked fairly similar demographically, with average ages low 50s. Roughly 1 in 5 had experienced a SCAD recurrence, and close to half were still dealing with post-SCAD health concerns at the time that they took the survey. I'll walk through what each group told us next. So this was a mixed method study, meaning we looked at both the numbers and stories behind them. Everyone was recruited through online SCAD patient communities, including the SCAD Hope Worldwide Facebook group, and the survey itself was created by Cheryl Martin of her Heart Sounds in collaboration with Dr. Stephanie Martin at UNC Chapel Hill, who served as the principal investigator in this study. For the qualitative side, we took everyone's written answers in the open-ended responses and ran them through a thematic analysis using a program called Atlas TI, where Cheryl and I coded the responses independently and worked through the themes together so it wasn't just one person's interpretation. And for the quantitative side, we ran statistical regression models in R, which is a data analysis program. And that part of the analysis was limited to female respondents, as only 25 men had responded to the survey, which wasn't enough to include them and get results that we could trust. Together, this let us look at how different factors connected to mental health outcomes after SCAD. When we looked at everyone's open-ended responses, 5 main themes came through clearly. The most common, by far, was psychological impact, showing up in close to half of all responses. Participants had described fear, anxiety, trauma, isolation, and ongoing distress, and some of you explicitly named symptoms consistent with PTSD. The second most common theme was lack of SCAD-related knowledge, both on the patient side and often on the provider side as well. A lot of respondents described confusion, care that took long to figure out what was happening, and trouble getting clear answers. The other themes were more treatment-related concerns, challenges with care after SCAD, and communication with cardiologists. As one patient described, the lack of information or treatment available is very distressing. Knowing that I could have another SCAD and they can't prevent it, can't predict it, and really aren't sure how to best treat it is very anxiety-inducing. I didn't like being treated like a typical heart attack patient because that's not what SCAD is. So this quote really captures the uncertainty and frustration that so many of you have described. And altogether, these findings show that SCAD's impact goes well beyond the event itself. So what do these themes tell us taken together? A few things stand out. First, there's a real and significant psychological burden here. A lot of you described lasting emotional distress, and for some, symptoms consistent with PTSD. Second, gaps in provider knowledge came up again and again in what people shared, and that often led to confusion or care that didn't come fast enough. There was also a clear mismatch between how SCAD is treated and how a typical heart attack is treated. The standard playbook does not always fit. And on top of that, a lot of participants described unmet needs going forward, especially around access to rehab and psychological support. And communication with providers came through as a huge factor in how the whole experience felt, whether patients felt heard or dismissed. Now, let's look at what those numbers behind the themes mean. Psychological symptoms showed up at notably high rates in this group. Anxiety was the most common, reported by over 70% of participants, and more than half said they didn't feel like themselves anymore, and close to half reported feelings of frustration. Depression affected over 40%, and isolation and anger were each reported by about 30%, and just over 1 in 5 self-reported a prior clinical PTSD diagnosis. We also looked at what predicted these outcomes using statistical models that let us account for multiple factors at once. A few patterns stood out. Age was consistently linked to outcomes. Younger patients had tended to report more distress, and that tracks with what other SCAD research has found too. Coming to terms with a sudden, serious heart condition can hit especially hard when you're young and didn't have any of those usual warning risks going in. So times in SCAD had mattered too, though not for every outcome. Having a recurrence was linked to worse psychological outcomes across several measures, and ongoing health concerns after SCAD turned out to be one of the strongest, most consistent predictors of all. The more physical concerns someone was dealing with, the more they were likely to be struggling emotionally as well. So digging a little deeper into those predictors, ongoing health concerns were significantly linked to several outcomes, such as not feeling like yourself, anger, and isolation. A SCAD recurrence was linked to worse outcomes as well, particularly higher rates of PTSD, isolation, and frustration. Time since SCAD was linked to lower anxiety and frustration, meaning symptoms tended to ease somewhat the further out people got from their event. And age was associated with several outcomes across the board, and younger patients tended to report more distress overall. So put together, this tells us what predicts how someone's doing emotionally after SCAD isn't just the medical facts of the event itself. It's also shaped by what someone's still going through physically and how recently it happened. So, taken together, these findings suggest that SCAD is associated with a substantial and often persistent mental health burden. The high prevalence of anxiety, depression, and emotional distress, along with what so many of you shared in your own words, shows that psychological impact extends well beyond the acute event. Importantly, these outcomes aren't random. They're influenced by both clinical and experiential factors like recurrence, ongoing health concerns, and time since SCAD. The qualitative findings give us more important context for these patterns, highlighting gaps in knowledge among both patients and healthcare providers, as well as real challenges in care and communication. Together, these results suggest that SCAD shouldn't be viewed solely as a cardiovascular condition, but as a complex survivor experience with real psychological and systemic components. So this study had several important strengths. First, the large sample size of over 1,200 participants is notable, particularly for a relatively understudied condition like SCAD. Second, the inclusion of participants from multiple countries adds geographic diversity and strengthens the broader relevance of these findings. The mixed methods design is also a key strength, allowing us to integrate quantitative patterns with qualitative patient experiences. In particular, the qualitative data provides firsthand insight into patient experiences, which are often underrepresented in the literature. There are also several limitations to consider. Because participants were recruited through online SCAD communities, the sample is self-selected and may be subject to response bias. It is also possible that individuals who are experiencing more severe or ongoing symptoms may be more likely to participate. Additionally, participation required access to online platforms such as Facebook, which may exclude individuals with limited access to technology or those not engaged in online communities. As a result, the sample may not fully represent all SCAD patients. These factors should be considered when interpreting the findings, particularly in terms of generalizability. So what does this mean going forward? A few things stand out. First, mental health support needs to be built into SCAD care more fully, and these outcomes are common, and for a lot of people, they don't just resolve on their own. Second, there's a real need for better patient education and provider awareness, especially given how many of you described gaps in SCAD-related knowledge. We also need to expand that access to SCAD-specific support, things like appropriate cardiac rehab and mental health resources that actually understand this condition. The good news is some of this is already happening. Her Heart Sounds SCAD stress management program is a direct example. It's an 8-week CBT-based program built specifically around the stress and emotional impact of a cardiac event, and it touches a lot of what came up in our findings: anxiety, not feeling like yourself, and difficulty coping. Her Heart Sounds also runs the Global SCAD Education and Support Session, which addresses that knowledge gap we were talking about earlier, and the Patient Liaison Service that connects survivors with psychological support referrals directly. So if any of what I've shared today feels familiar, there are already people working on it. And so looking ahead, future research should follow SCAD patients over time to see how mental health changes as recovery continues and start testing actual interventions that could help. Altogether, this points toward a more comprehensive, patient-centered approach to SCAD care, one that treats the entire person, the whole person, and not just the artery. So before I close, I want to take a moment to say thank you to my mentors, Dr. Katie Meyer and Dr. Stephanie Martin, for their guidance and support through this project, and to Cheryl, Jesse, Anju, Sarah for all their support along the way. I also want to acknowledge the SCAD Hope Worldwide Network and all of you, the participants who shared your experiences and made this research possible in the first place. And finally, thank you to my family and friends for their support throughout. Thank you.